discussion session. It's my pleasure now to invite Professor Oumar Gaye to give his presentation. Thank you.
Thank you so much. Thank you, Regina and the organizer, to give us the opportunity to share some experiences regarding drug efficacy, safety, and evaluation of drug resistance in IPTP and SMC. The first speaker talked about IPTP and address the key challenges we have so far. And right now, Professor Sandiko also talk about SMC, the two major chemo prevention strategies which is running now to prevent malaria within this vulnerable group, the children and the pregnant women. The malaria situation in the sustainable development goals in 2016, I state that pregnancy and child-related preventive morbidity and mortality remain unacceptably high. So really it was time to optimize the chemo prevention strategies for this vulnerable group. During a long time, chloroquine was the only drug we were using to prevent malaria in pregnant women, to treat also malaria, case management. And we face a very early problem of drug resistance, chloroquine resistance, spreading from the east part of Africa to the west part. And we have set in the region several networks as the OneMat, the InMat in the East African region, the RAOPAC also, Réseau pour la prévention du paludisme chez la femme enceinte and pregnant women. It was a network to address the disease, the prevention of malaria in pregnant women in the West Africa region. And all these different networks have set some research group to monitor the situation of chloroquine in the region. And the situation was that the resistance of chloroquine was very high, and it was time really to revise the different policy. And in the early 20s, the different national control program and the Ministry of Health has revised their policy, switching chloroquine to sulfadoxine pyrimethamine to prevent malaria in pregnant women. Sulfadoxine pyrimethamine and sulfadoxine plus mojaquine are widely deployed since this time. Professor Sandiko mentioned the story of SMC. And the challenge in the context of scaling up strategy to have impact, the main challenges will be the efficacy of drug, the resistance, and the safety when the different drug will be deployed widely. And it is the case. For the prevention of malaria in pregnant women, as I mentioned earlier, sulfadoxine pyrimethamine is used, and the different studies which is carrying on by this time, and mainly in Africa, shows the efficacy of the drug and the efficacy of this strategy. IPTP with sulfadoxine pyrimethamine reduce clinical malaria in pregnant women, it's now, reduce maternal anemia, reduce also placenta malarial infection, reduce the low birth weight, and reduce also neonatal mortality. Several studies have proven that, so we can be confident that the SP, when it is well used, have a positive impact on malaria in pregnancy. The main concern could be the resistance. This drug is widely deployed. The same drug also SP is used within SMC, and we can be a little fair that the resistance could be extended and expanded. It's why in the different region, we have set national and regional surveillance to monitor very closely the situation of the resistance of SP. At the global level also, we have set several networks. WHO is a champion on that. And we have also the worldwide anti-malaria resistant network, which has been set a couple years ago to address the issue of monitoring the different resistance regarding the different drugs, mainly sulfadoxine, pyrimethamine. The new tools we are using, there is a classical, clinical, and parasitological. But right now, the molecular tools as the best tool we can say it we use the collection, the collation, and the mapping of the different data. And with the molecular tools, really, we can have an update of the situation of the sensitivity or resistance of sulfadoxine pyrimethamine. Within the one, the worldwide anti-malaria resistant network, which has been set, we have several offices in the regional, regional office in Asia, in Africa, and the objective of one is a collaborative platform generating evidence to inform the malaria community on the factor affecting the efficacy of anti-malarial drugs. They have a tool, within one, we have a tool named the sulfadoxine SP molecular survey. We give us enough information at time. You can see in this slide how this is the different collation and the different collection, collation, and mapping of the different data give us an update of the situation of the SP resistant in the continent. Here we can see a slide. It's at UCAD University, my university, where we have open regional office of WARN. And within the office, we are coordinating and assembling and gathering the different data we can have from the region, mainly in West Africa. In East Africa also, the same regional office is doing the same activity. Here is a slide showing when we gather all these different results using molecular data, we can have a real situation of the sensitivity or resistance of, here it's a DHPS we use monitoring in West Africa. And we can say at this time, the level of mutation in DHPS is not too high, but it's present at a level of 47. Within the one, there is data as the published, collected, and mapped. And the situation that we can say right now, the regional distribution of key mutation indicates significant regional difference in SP efficacy. Mainly in Africa, the situation is different from the east and the west part of the region. If we take part, the situation of West Africa, in West Africa, only few mutation, the 540, and low mutation, the 581, was found in West and Central Africa. At this time, we can state that regarding the mutation of DHPS, the prevalence is low. It's not the case in East Africa, where we can see a review made by Kalirupen and a colleague since 2004, a systematic review to map the prevalence of the mutation regarding the HPS and show that the 540 and the 581 mutation, when they did a survey across Africa, shows that the 540 and 581 mutation increase in prevalence and in frequency in 60% of area after 2008, and this highlights the need for ongoing surveillance. So in East Africa, the problem seems very serious, and we can see with this new slide that the quintuple mutation, DHFR and DHPS, is associated in the region with clinical and parasitological treatment failure. And in certain foci, parasites have acquired an additional mutation, which I just mentioned here, it's the 581 mutation. And this report shows of 86 clinical failure and loss of protective efficacy in IPTP. And the meta-analysis they done, Kari and colleague, shows that IPT efficacy was reduced when the prevalence of the 581 mutation was over 10%. So this situation, we can say at this stage, seems a little critical. The prevalence of the mutation regarding the HFS is increasing, so we have to think about it and look at what will be the next feature. This slide shows how they map it, the 540 and the 581, more located in East Africa, as you can see. And the recommendation following all these results with these different studies have been made in West and Central Africa. And basing on the evidence, we can state it's a recommendation of WHO, IPT with SP remain effective in preventing maternal and fetal outcome, even in area where quintuple mutation linked to SP as prevalent. I have participated at different meetings in WHO since a couple of years, and what I can say at this stage is from meeting to meeting, we give a threshold for the IPT level of resistance, and saying even we have quintuple mutation, at a certain level we can continue to use ISP when in IPTP. But if we can look at the situation right now, we can say also and show and see that the prevalence of resistance in SP, mainly in East Africa, is increasing. And we can consider discontinuation of IPT with SP when the prevalence of the 581 mutation is over 10%, and the 540 is over 95%. 95% seems a very high level. We haven't reached this level, and as I mentioned earlier, time to time, so we increase the level, but at what level, what will be really the threshold when we will stop using SP is not known yet, but we can think about. I think the situation is very critical, and we can look at alternative. The first alternative in the early 20s was to use intermittent screening treatment and using TDR and a drug. It was at this time diazoxypiperaquine during antenatal care visit. The result was correct, in my opinion, because the prevalence and the incidence in pregnant woman, malaria in pregnant woman, decrease. And when you use it in the region where the malaria transmission was low and where there is high level of SP resistance, I can mention the study Professor Tagbor from Ghana made a couple of times ago. Other people also, all the research group have made this same statement, but this strategy has not been launched. There is no good publicity for that. I don't know why. But nevertheless, in the East African region, the Malaria Center group with Don Matanga and Julie have also done this study using intermittent screening treatment, and they found the same results, that it was effective for pregnant women, but however, there was not a clear benefit in terms of improved neonatal outcome. Maybe it's the reason why this strategy is not launched so far. But anyway, due to the level of resistance we are facing with SP, mainly in the African region, we can think about alternative and using other drugs such as mefloquine or erythromycin or other drugs we can explore more. For SMC, Professor Aleph Sandiko has reported earlier the story of this new strategy which is widely used in West Africa, in the sub-Sahel region. And we can mention, as Diko says, this trial Dr. Badara Cissé in Senegal and collaborator have made with the collaboration of London School, large-scale implementation of IPTC, and in 600,000 children in the region in Senegal. And it was a good opportunity, really, to look at safety, drug resistance, and efficacy of this new strategy in the West African region. The other groups also in Mali, in Burkina Faso, and in Ghana have done also several studies, and all those has proven enough evidence, really, to have SMC widely used in Africa, because it was a very effective strategy. Here we can see also another approach targeting malaria during the seasonal period, but also with a study piloted by Dr. Jean-Louis Ndiaye in Senegal, giving also increasing the age, increasing also the number of cycles. Efficacy is still there. Here we can see when we have made efficacy studies, the efficacy was there, proven by Alassane Diko, above 80% of efficacy. It is effective also regarding deaths in hospital. We can see also the deaths has decreased. It's a study run by Professor Jean-Louis Ndiaye. Also in Gambia, it was the same level of decrease of deaths when you use IPT SMC. The same also in Gambia. So in all these different studies, we have an effective reduction of deaths and morbidity in the children. Scaling of SMC, as mentioned also Professor Alassane Diko, the main concern could be now the problem of resistance of AQ and SP. Within the working group, we have set different protocol using the robust platform, and the different mutation also has been followed, monitored very closely. In Senegal also, we are using the rapid diagnostic test to monitor the resistance of the PFMDR, the PFCRT, also PF-DHPS and DHFR. Here we can see in the slides mainly in the West African region where SMC is deployed. The main results regarding the PFMDR mutation is still low, really above under 0.4%, and the main concern could be the raising of the mutation 540 in the most part of the region. So we can say in summary that the prevalence of SP-AQ resistance markers remain low. The mutation associated resistance to SP increase in prevalence, and few of 540 and low 581 is found in West Africa. The concern now regarding safety. Early in the working group, we have set a group with UCAD, with also London School, with WHO, and the IP, with the different groups also. These different groups have highlighted the weakness of the safety monitoring, and we have now a new approach really to strengthen the pharmacovigilance in the different groups. Here we can see what we have done so far, approach for strengthening the system with a regional safety committee. And pilot research have shown that the main concern of safety was the vomiting when 1 million doses of SP amodiaquine was delivered. No safety signal, no Stephen Johnson, and just one extrapyramidal syndrome has been reported. So we can say that SP amodiaquine is effective, is safe, and the recommendation of WHO pharmacovigilance and safety donc will be launched in all the different groups where SMC is deployed. In conclusion, IPT, SP, and SMC has been associated with the reduction of malaria cases and deaths attributed to malaria. Few serious side events have been reported. Pharmacovigilance system have been strengthened but need more support. Molecular markers associated with resistance to SP and AQ occur at frequency level still acceptable in west part, but in east, I'm a little skeptic. But this could change under strong selection and needs careful monitoring. And really, we think it's important to start identifying replacement for SP, for pregnancy, SP, AQ, for SMC before resistance expands. Thank you.